Hey, everybody. All right, so who needs it? I have these case history sheets here if anybody wants to grab it. What I will do after the session is, I believe I have all of these as virtual slides. So I will send out the handout with the answers and like the discussion and the link to the virtual slides after this, so that you'll be able to sort of look at them on your own and review them in light of the actual diagnoses. But since we didn't have time to preview them, we'll do it almost similar to like a frozen session where you guys just look at it on site and sort of tell me what you think as we go through. But obviously I won't expect you to have known or thought about anything because you didn't preview it, so we'll see how it goes. But this is what I gave at the interactive microscopy this year at UTEP and last year. So that was it. So this is the end of the IM session for this particular set of cases. So I think it'll be nice for you guys to see what they do. Have any of you done the interactive microscopy?
This is my first one,
personally. Before, yeah, so there's no arrow on this scope either.
Oh, last time we tried.
No? Okay. All right, so the way they do it there is they give everybody like 10 or 20 minutes to preview all the 10 cases, and then everybody sits around at the multi-headed scope and we sort of look and discuss. I don't think we have time to do that today where everybody goes and looks at them on their own. So we'll just look at it together. Okay, so case one is a 31-year-old female with left thyroid nodule, 2.7 centimeters on ultrasound, solid appearing papillary carcinoma on FNA. So they're mostly going to be follicular patterned neoplasms, because I think the differential diagnosis for these is tricky. Because classic papillary is classic papillary, so we're not really going to talk about that. We're going to talk about variations on follicular patterns and things. When applicable, I think it's important to look at the ultrasonographic kind of features and placement, and then the FNA, because you want to know that you're answering their question, right? And so I've gotten questions that sign up before, like, well, when do you make a comment if everything's benign or if there are multiple nodules or whatever? And the answer is, I answer their question. So if they're not FNAing anything and they're just like, oh, it's a multinodular goiter, like we're taking it out of the symptoms and everything's benign and there's no dominant nodule, fine, I won't address any dominant nodule necessarily. But if they're going after something or multiple things, I will try to address all of the things that they are going after by commenting on each of them individually and correlating sort of the FNA to the location in the thyroid gland and making sure that I am seeing what they thought they were seeing and addressing any potential discrepancies on FNA if applicable, right? So I want to make sure that everybody's on the same page.
I guess that's something we have to keep in mind when we gross as well, right? Odd number of nodules, dominant, how they describe it.
Exactly, and so when you guys, thank you for that. When you guys are grossing, it's really helpful to know that you made some attempt to find out what they did.
Yeah.
And comment on the gross of these lot things, exactly. All right, so 31-year-old female, 2.7 centimeters. Okay, so the challenge in follicular pattern neoplasms is always going to be trying to figure out if and when you can make a diagnosis of malignancy. All right, so the first thing you always want to look at is periphery. And in this case, the periphery seems quite well circumscribed, or even perhaps very, very thinly encapsulated, even if not thickly encapsulated. Okay, so we're dealing with a circumscribed thing. And secondly, then you want to look at the architecture. So what's the architecture in here? Mostly follicles, mostly papillae, combination of both. Shout your answers. Follicles. Okay, great. So mostly follicles. Then we want to look at, maybe occasionally we come across a tiny little papillary-like thing that's starting to poke into the lumen. All right. Then we start to look at the nuclear features. And what are the nuclear features that we're seeing? ton of irregular contours. These, I like to call them almost kind of like cup shapes. A lot of chromatin clearing. And whenever I see features like this, I ask, okay, one, how severe are they, right? How severe are the nuclear features? And how diffuse are they, right? Because that's gonna be one of the things that is gonna maybe help us into discovering whether something is more or less worrisome for an actual papillary carcinoma. So who is worried about papillary carcinoma here? Yes, we got a lot of hands raised. Okay, good. So what do you want to do in this case? What's going to help you? What? BRAF. Okay, good. So what percent of papillary carcinomas are positive for BRAF? Close. So interesting because if you look at older literature, people will say that it's like, I don't know, 40, 50, 60, whatever. But the cleaner your diagnoses of papillary are and the more you remove like the NIFT-Ps, which we'll talk about, and the non-true papillary carcinomas, the higher that percentage gets, right? So when we instituted BRAF here in 2016, I think it was 17, I can't remember. 18, I don't even know. We have found about like 85% of our PTCs to be positive, which is much higher than I think that reported in the literature, because the literature was diluted by a lot of things that weren't papillary being positive for BRAF. And so this is the BRAF. How do you want to interpret this? First, let's look at the background, because this dilution of this clone is different than what we are performing now. So this was the out of the box, like Roche B600E, VE1 clone, pre-dilute, that stained kind of weakly, but if it was diffusely, even weakly positive, that was enough. Okay, so look around the tumor. Pretty much every single cell of every single neoplastic cell has cytoplasmic expression. And the background is really, really cleanly negative. Okay, so this would be positive in our old stain. And in fact, this had BRAF V600E on molecular. Now the stain, Dr. Venkatraman modified the dilution to make it stronger because this wasn't picking up the hematologic malignancies, because I guess the amount of protein was probably less in those cells. So now it's a little bit dirtier of a background. So we just have to be a little bit more cautious in interpreting a BRAF, but usually the tumors tend to be really like strong and the background has a little bit of background wishy-washiness. Okay, so that's my comment on the immunostain. However, so we can regard this as BRAF V600E positive. That is always the first step that I would do when trying to figure out if something is truly PTC or not. And this is one of the rare, really, really well circumscribed papillary carcinomas that grows in 100% of follicles, in which BRAF V600E is going to be extremely helpful if you don't already have that information based on the FNA, because the pattern is so follicular and the thing is so circumscribed, right? Like usually your PTCs aren't going to have this problem. The other thing that one can do is try and look at more of the tumor. So in a tumor that's, small-ish, 2, maybe 3 centimeters, you can submit the whole thing. So this whole thing was submitted. And in one corner here, we have this area with much more robust kind of branching papillary architecture that is a little bit more classic, right, for what we normally see in PTC, with this dense squamoid cytoplasm, with these taller cells, with these papillae that are nice and branching. But this area was really, really only focal. Oh, there's a nice inclusion, right? So you see it? Okay, where?
Oh, I like where that more like fibrous.
Show it on the screen.
towards the top, like towards where that blood is. Oh, here.
Yeah.
Oh my god.
Is it on the screen?
Yeah, made a big fuss about
I
it.
completely lost it.
Anyway,
Oh no, I see it.
Where?
It's like, well, for me, it's the bottom. It's like the little, there's like a blob and then there's a little flicky thing. Here, I see it. Show me.
This-
right, hold on.
Point to it again.
Oh, I see it too.
Oh, yeah, got it. Okay. Yay. Yay. All right, I'm bringing it in the center. All right, so this brings up a few important points. So if your differential diagnosis is, I feel like we've all talked about NIFP a lot at sign out, but what does NIFP stand for?
Um,
Non-invasive follicular thyroid neoplasm with papillary-like nuclear features, which basically means a circumscribed thing like this, made up of mostly follicles like this, with nuclei that start to worry you for papillary carcinoma like this, right? By definition, those cannot be invasive, those cannot have BVF-V600E, those cannot have any good, well-developed areas of branching papillae like this do. Although, you know, we can argue about what papillae truly are, right? And lastly, in my opinion, shouldn't really have true good intranuclear cytoplasmic pseudo-inclusions. The only time I allow pseudo-inclusions is in sometimes oncocytic neoplasms can have them because they have convolutions in their nuclear membranes. But you should have other things that remind you of oncocytes, like granular cytoplasm, big nuclei, big nucleoli, which this doesn't have, right? This has PTC, real PTC nuclei, all right? So how do you define a true pseudo-inclusion? So for a true pseudo-inclusion, you should see the cytoplasm, which is pink in the cell. The cytoplasm, which is pink in the cell, right? Then the outer nuclear membrane, then chromatin, which in this case is kind of palish, right? Palish blue. Then another nuclear membrane, which is nice and crisp, and then pink cytoplasm again in the middle. So if it doesn't fulfill all those criteria, it's not a true pseudo-inclusion, because a lot of cells have artifactual vacuoles and crap that is not biologic, right? But this is biologic. This is a true intussusception of the cytoplasm into the nucleus, and if it meets all those criteria, then it's a true pseudo-inclusion, and I would really worry about PTC. Okay. What does it matter? Why do we care about this diagnosis? Yeah, so in a real PTC that's BRAF-V600E mutated, that's of a certain size or aggressive features, they may or may not do a completion. So now there's a tendency to be more conservative about management. So in small PTCs that are low risk of recurrence, that have few to no lymph node mets or small lymph node mets, they may not do a completion because they may not treat the patient with radioactive iodine because the risk of recurrence is really low. However, if you follow the ATA criteria, each more aggressive feature you get puts you at higher risk for recurrence. So it's not like a one-to-one, like yes and no. It's kind of a spectrum. It's like, you have size, it's bigger. Oh, you have lymph node mets. You have more lymph node mets. They're bigger. Oh, you have BRAF-V600E. Like every single thing that hits against you buys you closer to completion thyroidectomy and radioactive iodine therapy. So the fact that this particular tumor actually did end up having lymph node mets in one of these incidental parathyroidal nodes that come along with the specimen, right? Nice Samoma bodies. And it had BRAF-V600E, we're getting closer to buying the person completion radioactive iodine because their risk for recurrence gets higher, right? So that's what happens. It's a predictive recurrence risk that will buy you eventually completion in radioiodine. And so that's kind of why all of these little things are important. while we're here talking about these little parathyroidal lymph nodes, I'll mention when you're grossing, always look out for them. They tend to be towards the isthmus in the center. Usually there's not a ton kind of out in the lateral sides of the thyroid. But if you have a specimen that's a hemi, look near the isthmus. If you have a total, again, look in that fatty tissue that's kind of near the center, because some of those little nips and blips and bubble and bubbins or whatever could be lymph nodes, all right? And you don't wanna just ignore them, be like, snap, 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 isthmus done. Like if you see those little nubbins, maybe think about plucking them off separately and submitting them as lymph nodes, because in cases like this, we have found incidental micromets, you know, in these little incidentally plucked off lymph nodes that you see at the isthmus. The only time they will do a neck dissection, whether it be the central neck, right, which is level 6 and 7, or the lateral neck, which is 2, 3, 4, is if there is clinical or radiographic suspicion of lymph node involvement prior to surgery, or sometimes in surgery, right? Sometimes in surgery, they feel something that's a little hard and they take out level 6. But they won't really take out level 2, 3, and 4 unless there is a radiographic or clinical suspicion, which is why they do preoperative lymph node mapping with ultrasound for these patients. So don't if you get a neck dissection for PTC, it's probably because there's a clinical suspicion that there's something there. Okay?
I have a question about. You mentioned the size of the lymph node that matters. In this
Yes.
case, when they kind of look discontinuous,
Mhm.
how do you measure it?
So I usually measure the whole span
Whole span?
because you don't necessarily know that they don't connect
Right.
somewhere. So I would measure the entire span in this node.
Okay.
And that's also important when you're getting these neck dissections to measure grossly the largest size of the largest lymph node that you see, especially if it's grossly involved, because sometimes when you cut it up, we histologically lose the greatest dimension, right? Because if you're cutting it against the longest dimension, we can't recreate that measurement on the slide. You have to give it to us in the gross. So I really, really do pay attention to the sizes of those lymph node mets that you give me from the gross description, because if the tumor is filling the lymph node and you've given me that gross measurement, I will use that as the largest size, and that will determine, help determine what this patient needs. Yeah.
Extranodal goes into the size or counted separate?
Extranodal goes into the size, so I don't discriminate between the size of the tumor that's in the node and the size of the tumor that's out of the node. I just consider it all one. But yes, every single head and neck case, whether it's thyroid, whether it's squamous, whether it's salivary, all of them, we need size and extranodal extension to be mentioned, presence or absence in our synoptics. So I don't know if it's the same in other organ systems, but uniformly in all all head and neck, those are the two things we need. Okay. So that's BREF V600E, classic PTC with extensive follicular growth. You may ask, do you call things follicular variant anymore? And my answer is no. I don't use the term follicular variant because I think it's fraught with historic problems. Some of which were true papillaries, some of which were nipped peas, and I don't use it anymore. I just say papillary carcinoma with extensive follicular growth. Yes.
That was the case one, right?
I know, we've taken a long time because there's a lot of
No,
time.
I walked in late and I was.
Oh, yeah, that's still case one. And I said earlier that I have these all as virtual slides. So after this, I'll send out the link to the virtual slides and the answers so that you'll have it all, so you can look at them independently, yeah. So I don't have I know you asked for a PowerPoint, but I don't have a PowerPoint for this. All right, so the next case is a 71-year-old, no, you can, all of my old PowerPoints and stuff are on the, should be on the M drive. All right, 71 with left thyroid nodule, 2.7 centimeters, hypoechoic, FLUS, follicular lesion of undetermined significance on FNA. So always low power, right? Circumscribed but unencapsulated, and then a little bit of kind of fragmentation at the periphery, fine. Growth pattern. Follicular. Sometimes the follicles are larger, right? Sometimes the follicles are mini and they're like really compressed, right? So if you recapitulate this to FNA, usually what you'll see are these tiny little microfollicles, right? Like little florets that are really tiny and lots of them, right? So that microfollicular pattern is a clue to kind of what is important and what we may be dealing with. All right, now let's look at the nuclei. Some areas, arguably, these are really round, right? Like these are really round to me, but cleared. And then in other areas, they get even more clear, right? We don't want to focus in on just one area. We want to look all around because, as we said, the severity, the intensity, and the diffuseness of the nuclear changes might suggest one way or another whether we're dealing with a true PTC or not. Because the more you start striking against you, the closer you get to becoming a real PTC. So arguably, these are very clear, somewhat wrinkled, but arguably, most are quite still very round, right? Most are very round oval. So who wants to do what in this case? Ignore it, call it an adenoma, call it PTC, or do our ancillary test. Do the ancillary test. Okay, so you do your BRAF V600E and it's negative. And what? Can it still be PTC if it's BRAF V600E negative?
Yeah.
It could, right? Because the some have RET or NTRK fusions or BRAF fusions, and those are arguably still PTC. What kind of molecular profile could it have that really you don't want to see in a class of PTC? RAS. So tell us about the difference between the RAS and the BRAF.
The morphologic difference?
No, the genetic soul difference.
RAS mutation, including in RAS, KRAS, so on. In HRAS, they like to be found in the follicular lesion. They can be found in the benign follicular lesion, but you can accumulate more mutations to become malignant, and it's generally mutually exclusive with the other things that are found in PTC.
Yes. So if you don't have BRAF V600E, you're getting closer to not being PTC. But if you have a known RAS mutation, you pretty much, I would not ever call that PTC, because we know that there's sort of this dichotomy between the BRAF V600E like cases and the RAS like cases, and I'll give you this BRAF RAS score thingy in the handout. But you know, the problem we got into in the past was that these non-invasive encapsulated follicular variants of PTC that have RAS mutations, if they didn't invade, they didn't metastasize, and they're effectively benign, right? So that's the category that NIFT-P fell into. So this, what I would look at is I would always look at the cytology, because when you have something that's FLUS or AUS or follicular neoplasm on FNA, those are the ones that often go for the molecular testing on the FNA, right?
Yeah.
On the FNA. So sometimes their molecular status is already known to you. So dig in the chart. This had NRAS, all right? So this had NRAS Q61R. So this would be not a PTC. I would throw it in the adenomatous nodule with nuclear atypia / NIFT-P bucket, right? And so those of you who've signed out with me know that I don't top line my diagnoses as NIFT-P because I think it's a lot of words. I call them adenomatous nodules with nuclear atypia or the cytologic atypia or architectural atypia or whatever with atypia. See comment, oh, by the way, this would fit the criteria for what we now know as NIFT-P, but basically these are adenomatous nodules, you know, with nuclear atypia. So follicular neoplasm with nuclear atypia for me is basically NIFT-P. Okay, I just wanted to show you a second example of another case that was probably called benign on FNA because it has so much colloid, right? Like it's so colloid rich. Well, if you're somewhere out in the world and you start looking, you know, some of you might start seeing some wrinkles and grooves and irregular nuclear contours in a macrofollicular lesion, right? So now we're getting even farther away. We have follicles, but we have wrinkles and grooves and whatever. And so this also had a RAS mutation. This had another NRAS. So be mindful that we don't really know whether something is neoplastic just based on looking at it, right? You might have called this a colloid nodule, and you are not wrong. But molecular tells us that this has a recurring RAS anomaly, so it's actually neoplastic. And so this is why we're kind of getting away from the nomenclature of hyperplastic nodules or colloid nodules or whatever, because even the ones that look, you know, quote unquote macrofollicular or maybe hyperplastic, you don't know, like you cannot tell based on looking at them. So the WHO now basically advocates for not calling anything a hyperplastic nodule, but for kind of being descriptive of what it is. And if it's a solitary nodule like this, I would call it adenomatous, right? Meaning I don't know whether it has a mutation or not just based on looking at it. Or if you have multiple of these without a dominant one, who knows what the new WHO term is? So follicular nodular disease. So previously multinodular goiter or multiple hyperplastic nodules or multiple adenomatous nodules, whatever. If you see multiple of these without a dominant one, the suggested term now is follicular nodular disease, because some of these end up being hyperplastic truly, and some of them end up being neoplastic, but like I said, we can't tell. So that's why no more nodular hyperplasia, no more just, yeah. But the FNA counterpart is still benign follicular nodules. You are correct, right? You are correct. I wouldn't call it a hyperplastic nodule.
Yes,
You don't know that, but if you call it benign, you're right. Okay, so all right, in the handout, I've given you the specific criteria for NIFT-P. But some of them I think are good criteria and some of them I think are less good criteria. And I don't want to get into that now because we've got a lot to do, but maybe as we go through, we can talk about what I think are good and what I think are bad criteria. Or on YouTube, I have a whole hour-long lecture on NIFT-P. So you can also go back and watch that if you want. Case 3. Right, we've got some chronic lymphocytic thyroiditis in the background. We have a pretty circumscribed nodule. But with the diagnosis of NIFT-P, as in the prior case, you know, or adenomatous nodule with nuclear atypia, or neoplasm with nuclear atypia, they will stop, right? They will not do a completion. Because in a RAS-like neoplasm, if it is not invasive, it's not going to go anywhere. So in a BRAF-like neoplasm, if it's not invasive, it may go somewhere, right? Like you saw in the first case, it was totally circumscribed and not invasive, but it already went. So we know that there's a difference. So RAS-like non-invasive won't go anywhere. BRAF-like non-invasive probably is already invasive, we just can't see it, all right? So then this one. Circumscribed follicles. What'd you say?
I don't like this corner.
I don't like this corner. Corner starting to actually get some papillary structures and hemorrhage. And what do we do? Are they true papillae? Are they not true papillae? How about the nuclei? Pretty round. And Okay, most of them are pretty round and you've got these weird papillary-like projections into this large space. So this was in the time where I didn't know what to do. I think I called this follicular, mostly follicular pattern neoplasm with some papillary structures and some nuclear atypia. Probably a NIFT-P, but I don't know why there's all these papillae. So then I did molecular. Okay, I mean, I did molecular because the BRAF V600E stain was negative, right? Always start with that. But then I was worried enough that I sent this for molecular, and I think that's the good thing we have here is that we can do that. Oh, look at these little papillae. They keep popping up. Who wants to guess? Who wants to guess what the? No, I won't make you guess. I won't make you guess because I could not have predicted it. So this had a BRAF fusion. So this has an SND1 BRAF fusion. So then when I don't know what a fusion means, I go back to the TCGA, right? And I pull that paper because every single gene anomaly that they described is there somewhere. It's either in the materials, sometimes it's buried in the supplementary materials. If you find a thing that you don't know what it is, go to the TCGA or go to the literature and see what people have described. So, you know, they not only looked at what the actual mutations and fusions were, but they looked at the global gene expression profile of these things and was able to map out the gene expression profile with how strongly it was BRAF V600E, you know, like with each of the individual point mutations and fusions. And if you look at the BRAF fusion line, all of these little tick marks sort on the BRAF like sided bar. All right. So I was like, well, it doesn't really look like classic PTC to me, but they've told me that the gene expression profile of the BRAF fused tumors is more like a classic PTC. So I can't ignore that. Like I cannot ignore that. And I have to go back and revise the report and call this a classic PTC with unusual morphologic features. Whether this didn't have any metastases at the time of presentation. It's small, it's circumscribed, BRAF V600E negative and no nodes. It may still qualify the patient for observation rather than completion thyroidectomy, but maybe the index of suspicion for if this is going to recur or metastasize in the future is higher than if it were completely RAS-like, you know, non BRAF V600E-like thing, right? So I'd have to check what happened to her. But what's the thing going against it for her? It was 4 centimeters, right? So now the bigger something gets, the more they start to worry. So this is why I'm really, really cautious with these things, especially if they are not BRAF positive and not RAS positive. It's all these ones in the middle that every single tick mark you get buys you something or doesn't buy you something, right? Because it's, as I said, it's not a linear like on-off switch. It's every single thing they all take into consideration. So because this was bigger, I think the risk for her was probably worse. I think they actually probably did do a completion on her.
I have a question.
Yes.
So I guess I was always thinking about like BRAF V600E to be diagnostic, but then I guess because there's those that are negative, is it also like prognostic? Like do the
Yes.
fusions, are they better or worse or?
Yes, so it's thought that the non-BRAF V600E genetics, such as the BRAF fusions and the RET PTC fusions, are less bad prognostically. It is thought because historically patients with BRAF V600E did worse than patients without BRAF V600E. I'm skeptical because I don't know how many papillary carcinomas were diluted in our historic data by what is now NIFT-P, right? That in the past was called PTC follicular variant. So I don't know if BRAF, so this is one of the things I want to look at in our population is BRAF V600E really worse, or is it just artifactually worse because we had all these RAS tumors in there? The only fusion that is not theoretically good prognosis is NTRK fusion. So the NTRK 1 or 3 rearranged PTCs are thought to actually be somewhat biologically aggressive for reasons that we don't understand. So BRAF fusion, BRET PTC fusion, I would argue probably on the lower end of the prognostic line. People regard BRAF V600E as on the worst prognostic line and NTRK as on the worst prognostic line because those tend to have lots of lymph node mets. They can have visceral or distant mets. With, I don't know if I have an NTRK one in here, but I can send you one on the virtual slides. What you'll see is the NTRK 1-3 bar here on the bottom. These tumors cluster right here. And some of them are like narrow on the BRAF V600E like, and some of them even cross over a little bit into the RAS like. And so I think these NTRK 1-3 tumors are kind of hybrids in terms of they have papillary like look, but they tend to be follicular patterned. They tend to be highly infiltrative. They can have lymph node and visceral mets. So they kind of they straddle a little bit this genomic spectrum. And I think that's why they potentially behave bad because they can go to lymph nodes, they can go to visceral sites. They're super highly infiltrative. But that's my word on the genetics.
Suspicious should you be like, I feel like when I looked at literature, which is probably old, but if papillae, that's, that basically buys you a diagnosis of PTC.
Yeah.
So when, in this case though, you had papillae, but you were still skeptical that it was a PTC.
Yes.
So when should you be skeptical?
Yes. Yes. So I think that papillae are not all created equal. And so there's, no, not this case. There are some cases that have immense amounts of papillary architecture and yet have RAS mutations. So what I'm skeptical about is I've seen cases that look like this where they have papillae, but the cores aren't tight, right? The cores aren't small, the cores are wide. And within the core are actually other follicles. So to me, I don't know if these are true papillae or just like septations, right? That are geographic and there's like folds into the lumen, right? And so I've seen cases like this where the papillae aren't tight, they're not branching, right? And they have these follicles or this extensive kind of hyalinized stroma in their cores rather than just like one narrow little vessel and done. And I've seen tumors that look like this morphology that have RAS mutations and that are completely non-invasive, and I would not regard those as PTCs at all. And so it's the morphology of the papillae that is, to me, confusing. And it's in cases like this where I'm like, I don't know, because it could go either way.
But if you really branching and all that,
the closer I get, the more tighter they are with thin cores and complex branching, and then like increasing dense eosinophilic cytoplasm, like all those things start to add up to be like, okay, this is a little more real. And so that's why the 1% papillae thing versus the 0% papillae thing is still under debate. Like in the NIFP criteria, the revised criteria from 2018, it went from less than 1% to 0% are allowed. But now there's papers in the literature that are like, well, we've shown that even up to 1% papillae still don't metastasize and still do really prognostically well. So I think it's not quantity. I don't think it's quantity. I don't think it's 0 or 1. I think it's quality of the papillae in combination with the genetics. Because I think what we think about thyroid is just being blown out of the water because
papillae don't matter, nuclei don't matter, right? Like what matters is like the underlying molecular soul of these things. And we can't see the molecular soul because there's so much overlap. There's so much overlap.
Rather than on H&E, just throw them for molecular, spit out the
Spit out,
molecular,
yes.
then I'll look at the H&E.
That'll
That'll
look And that's why having the molecular on FNA for me has been a game changer, because like if I have that knowledge, it really informs my diagnosis. And I really believe that we should be practicing like we do with brain tumors and bone tumors and sarcomas and thyroid, because like it matters. Like it's really important to have this, but we're so used to doing it for heme and for sarcomas, but we're not used to doing it for thyroid, because like chances are this is not a high grade cancer and this person's gonna do fine, right? People don't care because the prognostics aren't that severely different, right? The prognostics for these low risk neoplasms are generally all still good, right? I'll show you some when we start to get bad, right? So what does bad look like? These are the things we have to actually be careful for. Since we're running low on time, I'll skip to a bad one. I'm gonna skip. Right, I'll give you 6. This is a young person now. You're like, oh, she's young, it's probably fine. Suspicious for follicular neoplasm on FNA. We have a really thick capsule now. We have areas that are macro follicles. Ugh. Now we're getting solid and micro follicles. No, it's these areas now I start to worry about. So that's why sometimes I ask you guys, all right, when you see an encapsulated follicular neoplasm, you don't necessarily have to submit the whole thing right up front on grossing, but like, let's look at it. And like, oh, it's getting really solid. I don't like this. Right? This is one I'd go back and submit more on. And the nuclei are round and there's focally cleared, but they're also focally stippled. So I'm not really thinking PTC in this case, right? The chromatin is kind of fine. I'm starting to see mitoses now. There's one in the center. Mitoses, solid growth. I'm worried, so I go put more in. And we look at the edge for invasion. See that. Maybe put in more of the capsule because we want to see if it's invasive or what. So the one thing that's on this slide that worries me is this. What? Okay, so is it L or is it B? Angio, yeah. So in thyroid now we have to discriminate between lymphatic and angio. And so lymphatic invasion, right, tends to be small vessel, tends to be classic PTC. Angio tends to be large vessels that are in and around the capsule. Sometimes you can see a muscular wall. Maybe arguably there's a hair of a muscular thing there. And tends to have thrombosis in these fibrin thrombi, and tends to have adherence to the wall in fibrosis. Like look at that nice fibrous adherence to the wall, and tends to be endothelialized. Or there's a little, oh, there's more muscle, right? There's a little more smooth muscle in the wall, right? So this is angio invasion. So lymphatic invasion we care less about because many PTCs have it. Angio invasion we care about, because whether it's angio invasion in a PTC or angio invasion in a follicular neoplasm, of course it buys you a diagnosis of cancer in an otherwise encapsulated thing, right? And it buys you an increasing risk for distant visceral metastases. Okay, so this person has a lot now going against her because she's got angio invasion and she's now got some arguably solid growth. So then we have to ask ourselves, okay, we can at least make a diagnosis of cancer because of the angio invasion. Number one, what type of cancer would you favor in this patient? Follicular, okay. And then once you've made a diagnosis of cancer, you have to ask yourself, can it be worse? What's the worst? What makes it worse now? What are the criteria for making it worse than just follicular? Mitosis and necrosis. Okay, so the one important thing that I wanted to get across with these couple of cases here is there's now this thing called high-grade follicular cell-derived non-anaplastic thyroid carcinomas. We used to think only about poorly diff, right? We used to talk a lot about poorly differentiated carcinoma. But now there's this other category called differentiated high-grade thyroid carcinoma that captures other high-grade carcinomas as being more biologically high-grade that don't meet the Turin criteria for poorly diff. Right, so for poorly diff, you need, I don't know if this is it. I don't know. You need solid growth. You need solid growth in the Turin criteria. Oh, this is it. All right, so here's a tumor that's got follicles over here, and then more of this kind of solid stuff over here. So in order to be called poorly diff, you need kind of compressed solid growth, where you walk through a bunch of cells without coming across stroma or without coming across colloid, right? Yeah, okay, there's one follicle here and one follicle there, but you can walk through a pile of cells without encountering any other structure. You are solid or insular or trabecular, right? So to be poorly diff, you have to have that. And then you also have to have what? Necrosis or mitosis. However, even if you don't see solid growth, you can still be high grade. Here's nice solid growth. If you have necrosis or increased mitosis, right? So the important thing to look for is necrosis and increased mitosis. The subtle clue that you might be dealing with something higher grade certainly is if you start seeing solid or trabecular or insular growth, right? So when I start seeing the collapse of the architecture into this, where I get wall-to-wall cells with kind of punctuation by follicles here and there, that's a clue that I'm going to start worrying, and I'm going to go start submitting more. But you can have high-grade cancer that doesn't have solid growth, but that has a ton of mitoses and or necrosis. And so only because, look, even in this follicular area, even in the non-solid area, you can start to see mitoses. There's a nice one in the center, there's another one up there. So be mindful of mitoses in invasive neoplasms because it might buy you high grade. The validation criteria for each of these studies, for the poorly diff, for the Turin, they want 3 mitoses. For the high grade diff, they want 5 per essentially 10 high power fields. Some have argued, well, should we make both the same? Should we make both 3? Should we make both 5? I don't know what's going to happen, but just at least have it in your brain that like maybe something can be high grade, even if it doesn't have solid growth.
So what does high grade not have versus poorly?
What?
Like what Turin criteria does high grade not fulfill?
Oh, so the Turin criteria that high grade does not fulfill is solid growth.
Okay.
So you can have solid growth in a high grade. You don't need it. You need for both necrosis or mitosis. You need solid growth for Turin. You don't need solid growth for high grade. So I'll show you a high grade that, because of this difference, most of the things that were called poorly diff in the past tended to arise from follicular carcinomas. And now high grade diff tends to be papillary. Oh, the other thing for the Turin criteria that you need is you need absence of papillary-like nuclei, right? So you need follicular nuclei. So most of these are high-grade follicular carcinomas, right? That we call poorly diff. For the non-Turin, you don't need solid growth, and so any growth pattern and any nuclei. So mostly these end up being high-grade PTCs. So this is an example of that, right? So this is a thing that's got a crap ton of necrosis here in one corner. It's got a well-developed area here that looks arguably quite good for probably a PTC, right? It's got thick cells and wrinkles and, okay, kind of complex architecture a little bit. And it's now even got some solid areas here with disc cohesion. But you look and you say, well, this is still, it's still kind of capillary. I mean, if you look at the nuclei, they're still pretty wrinkled and grooved, and they don't exactly look like that other case, right? They don't look like that other case. So this in the past was just, okay, PTC, you know, next case with necrosis. But now we actually have a place to put this that isn't just, oh, PTC with necrosis. It's actually PTC with necrosis equals high-grade PTC. And they want to see, oh, look, see, there's still even inclusions. There's two right in the, see them?
Yeah.
They're like looking
They're
at
like
us.
twins.
Yeah. So, you know, this hasn't lost nuclear features of PTC. So technically it doesn't meet Turin, but it's solid and it's got necrosis and it's nasty, so it's high grade.
How do they treat them differently?
So they will definitely, they'll be a little bit more aggressive. They'll definitely do completion with high dose radioactive iodine. What they might also consider is targeted therapy. So this is BRAF IHC in this case. And again, it's weak, but it's arguably positive right in this area here. So they may consider BRAF inhibitors. If it were like an NTRK rearranged type of tumor, they may consider an NTRK inhibitor. So they will be more aggressive up front rather than wait for it to recur. Because sometimes with well-diff carcinomas, they do RAI. You know, if it meets risk criteria, they'll do completion with radioactive iodine and wait for it to recur. And they'll save targeted therapy for when it's more out of the box. But because these are predicted to behave even worse, they may upfront do the targeted therapy, or at least consider it.
We have a question on the chat.
Yeah.
For practical purposes, if we have mixed nuclear patterns shared between follicular and papillary, but have more solid and follicular pattern of growth, would we definitely do BRAF IHC on all, considering you don't have NGS on?
So one, if you have mixed features, I would argue that it's probably not a PTC because the nuclear features of PTC should be diffuse. So if you start having totally bland looking nuclei, I would vote that it's not going to be BRAF positive. However, yes, you should do it. You should do it because then if it's BRAF negative, then you are going to want to pursue other genetics. And in fact, this is often in the hands of the clinical teams. Here, our clinical teams are very aggressive with molecular, and they will want molecular on anything that is not well diff or classic or out of the box, right? So especially with BRAF V600E negative, they'll, on all of our high grade and all of our poorly diff and in all of our anaplastics, they'll want molecular because they'll want to look for targeted therapy. Or they'll want to look for a high risk mutation that is not therapeutic, but prognostic. So what are the other high risk prognostic mutations that they're going to be on the lookout for? TERT promoter, sometimes TP53, and especially a combination of BRAF and TERT or RAS and TERT, because the combination is actually prognostic of even worse behavior. So yes.
Is there a recommendation on when they recommend molecular testing to be done?
So it's pretty much all anaplastics, and it's pretty much now also the high grade / poorly diff clinically. So we do it on those for treatment and prognostic purposes, and I also often do it on the well diffs for diagnostic reasons, right? If I'm not certain whether something is this or that.
Yeah.
What else? Okay.
NGS on the cytology now for which cases?
So you can do, all right, so we do pre-operatively molecular testing on FNA that are indeterminate. So those that are not benign and not malignant, like the flusses, the AUS, the follicular neoplasms. We don't do that here, we send that out because here we don't do the genomic profiling, we just do point mutations and fusions. But these companies out there, they do that genome mapping. They do the microRNA or the messenger RNA mapping. Because if you don't have a mutation or a fusion, you can still look at that profile and say, oh, this profiles closer to something that we think is benign or profiles closer to something that we think is malignant. So it's really helpful in those cases that don't have a mutation or don't have a fusion to see what the underlying profile is. If then that underlying profile is favor benign, that's when the surgical decision-making point is made and they say, okay, we don't go to surgery now because you've taken a cytologically indeterminate neoplasm, no mutations, no fusions, and low-risk profile, you've put it into a molecularly benign group, right? However, if there is a mutation or a fusion or a high-risk thing, then that pushes them to surgery. Then it's when I use that molecular to inform my decision. If I don't have the molecular from the FNA and I'm confused, then I will do it on the FFPE. So that's kind of how the algorithm that I use works. You can, the place that we use, Interpace, they can do molecular off of cells collected in their medium. They can do molecular off of a smear, like a diff-quick smear. And they can do molecular also off of FFPE. So on occasion, we've had core biopsies of thyroid where it's like follicular, basically fluss. And so they can also do that same thing off of the FFPE tissue. Can I answer your question? It's 9 o'clock.
We've gone through like exactly
Yeah.
half the cases,
Okay.
well, less than half actually, 'cause we have 9.
Yeah,
I mean, I personally would love to have the remainder done sometime in the future, if
Yeah.
you are okay with it.
yeah, you know what I'll do? I don't wanna hold off on this because I don't know when we're gonna get them. The others are not that interesting. I've picked up the more interesting ones, but I'll send, why don't I just send you out the virtual slides and the answer key? And then if you decide you want to review the others, we can. If you decide just looking at them on your own is fine, then we can just do that.
Okay,
How
sounds
about-
good, yeah.
Okay.
Worth the $79, but thank you for not making it.
You saved us about $1,000.
Some perks, right?
I mean, what's the who doesn't have a case history sheet that wants one? Two over there.